Okay, good morning, everybody. My name is HEEMOON KYUNG from Korea. I really appreciate Charlie who invited me in this wonderful meeting. So anyhow, my English is not so good because English is the most difficult language to Koreans. Also, Korean is the most difficult language to Americans.
Thank you.
Okay. Okay. Today I'm going to talk about a little bit basic things. I'm not going to show many cases because already you've seen so many cases from lectures and articles and the textbooks. First, I introduce by myself. I finished my DDS degree in 1980s. Then I entered 3 years specialty program. Then every Korean man have to join the army. I spent 3 years in the Navy. After that, I returned to my university. Then I start to teach. So one of my job is to teach students. During my career from 1991, I've been to Osaka University. Then 2022, I was retired. In Korea, when in age 65, we have to retire. The system is a little different from the USA. And at that time, I met Professor Takano Yamamoto. She is the number one in cited articles in orthodontic field during the last 7 decades. Number 2, Toru Teguchi. Now he's the chairman of Louisville in USA. Number 17, Dr. Kuroda. Unfortunately, he passed away. Anyhow, I was ranked number 18 because of good cooperation with them. I did the lecture and the courses more than 60 countries. Also, one time, several years ago, I did a microimplant anchorage course in this NYU. Okay, every year I have to teach my students. We accept 3 orthodontic residents every year. As you know, Dr. Engel is the first. Okay. Modern orthodontics start from Dr. Engel, as you know. He designed 4 main appliances. Anyhow, Engel's concept was non-extraction, even though he did extraction at the initial stage. There are 2 famous students. Of course, one is Dr. Begg from Australia. Second one, everyone you know, Dr. Charles H. Tweed. I have no idea about Vega mechanics, so 2005 I attended a Vega course in Adelaide. And Vega's concept I learned is differential force mechanics. Anyhow, he didn't think about anchorage a lot, I think. So 2005 I attended Vega course. However, they already changed original Vega brackets to this kind of Tibet appliance. So I think there is no one who uses Vega brackets anymore. As you know, Charles Tweed is the most important doctors in modern edge-wise mechanics, I think. And he became a student of Dr. Engel in 1928. Unfortunately, Dr. Engel passed away in 1930s. And he learned orthodontics for 2 years from his teacher, Dr. Engel. According to articles, every 4 months he visited Dr. Engel's house and he discussed and returned, then treat without extraction, as you know. However, he found a lot of relapse and the facial imbalance. So anyhow, after 5 years practice, he was so disappointed with his result. So he studied his cases and retreated several cases by extraction for first premolars. This is very famous display in 1940 in Chicago area meeting. As you know, he displayed 100 cases. Of course, the first row, initial model. Second one is finished without extraction. Third row is relapsed, then extract 4 premolars. Then he displayed 100 cases. Then from these cases, he made this kind of the famous Tweed triangle. And I think Dr. Tweed is the first man who emphasized importance of anchorage in orthodontics. I attended this course 1990, but at that time already the original Tweed mechanics was changed. All the mechanics and the diagnostic tool is focused to treat class 2 medical region. Because in Western society, you have so many class 2 patients. But in Oriental society, it's absolutely opposite. In my university hospital, half of the patients are class 3. And I learned how many sets in original Tweed mechanics. I never tried in real patient. Anybody knows how many sets in original Tweed mechanics?
How many people know what, sorry?
Yeah, how many? Raise.
Could you repeat the question? I can't really
Okay.
hear you really well.
Do you know anyone how many sets? How many sets in original Tweed mechanics?
How many sets?
Set 1, set 2, set 3,
Sets?
yeah, set 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. I just tried on the typed not real patient. And he said anchorage preparation is the most important step in clinical orthodontics. You know this famous movie? This was kind of anchorage preparation. So he want to tip molars looks like this study. So he divided into 3 categories: first, second, third. His first degree anchorage preparation, just slight tipping or last molar in the mandible. Second, more. Third, all posterior teeth tipped distal. Then why Dr. Tweed made his mechanics so complicated? Why anchorage control is important? This case referred from Germany 7 years ago. This is one of my friend's daughter. The doctors, maybe young doctors, promised to finish her treatment before graduation. However, this is her situation when I first saw her. I was very happy to see this kind of case again, because also when I was chicken, also I had this kind of problem a lot. You can see typical side effect. Transverse bowing and vertical bowing and losing of anchorage. This is very common when you extract premolar teeth. Then we retract anterior teeth back without thinking of biomechanics and without the thinking of anchorage. Always, every year, I told to my student, orthodontists spend lots of time to treat iatrogenic malocclusion, which was created by ourselves. I think Dr. Tweed also met this kind of situation a lot. That's why he made his mechanics so complicated. Then he realized that anchorage preparation is very important in orthodontic field. And in conventional mechanics, the difference between expert and the beginner, I think, anchorage control ability. I learned so many different kind of mechanics and the diagnostic tools with my beloved teacher, Professor Sung, but none of them satisfied me. And in 1986, my teacher attended Tweed Medfield course. Then we start to use Tweed Medfield technique It's main technique in my university hospital. Because in Oriental society, we have so many high angle cases with bialveolar protrusion. Always we need maximum anchorage. And then Merrifield already, as you know, he changed from 14 sets to 6 sets. Still, I'm teaching this mechanics, my student in my clinic. And then the biggest problem of treating Merrifield mechanics is we need patient cooperation. But many doctors hesitate to use extraoral appliance. So that's why many doctors developed many intraoral anchorage device. One of the most popular one is transparent arch, as you know. Okay. I always ask my student, when we treat crest 1, crest 2 medical region, I always ask my student to put TPA. And we can prevent that kind of transverse bowing. Also, it can increase the anchorage because it can keep intermolar width. So if we keep intermolar width, if the first molar move medially, the root will touch to the cortical bone. Also during swallowing, we can have this kind of intrusion force. So these days, many doctors use bonding instead of bending. So during treatment, sometimes I need this kind of transparatal brackets. So that's why I made this kind of 2 slot. I named it translingual brackets. Inside, we can insert one more arch wire to control the neighboring teeth. Also, inside, I can use this kind of leakage wire, then tie to the first molar. Then we can prevent going away when there is bonding failure. Why skeletal anchorage? Dr. Moyes, when I read his book, there is one phrase: the patient determines the success of treatment. It means even though you're excellent orthodontist, you cannot have good result without patient good cooperation. That's why many doctors try to use skeletal anchorage. Dr. Klingmore, he is also lingual orthodontist too, and Eklund used this kind of a surgical screw. However, in this journal, they didn't mention about size of these screws. When I look at cephalogram, maybe almost more than 2 mm diameter. However, nobody tried to use this kind of dangerous tool in orthodontics in their daily practice, including me. However, in 1997, Dr. Kaname in Japan, Osaka, he introduced this kind of a K1 system. K1 system is made of grade 1 pure titanium, very weak, and diameter was 1.2. Anyhow, he showed us very, very important information that even though 1.2 mm diameter is enough for orthodontic anchorage. As you know, intrusion is the most difficult to smooth. That's why Klingmore and Kaname use this kind of implant for intrusion of anterior teeth. This is the first case in Korea. One of my students tried to use this kind of surgical screws to intrude first molars. However, it was failed. It's a little big. Finally, we found the same diameter of surgical screws, which were used by Dr. Kaname, 1.2 mm diameters. I want to buy the Kaname screw, but they didn't sell at the time because they didn't receive any certificate from the Japanese government. Anyhow, we found the same diameter screws. Then we tried to insert in between roots. Then we tried to retract anterior teeth back. The first microimplant failed 4 months later. If we can use 4 months, it's good. Usually, anchorage loss occurs during angmus retraction. So 4 months is enough to retract anterior disc at the time. Then we use so many different kind of mechanics. I'm not going to talk about biomechanics today. Anyhow, I made this kind of slanted neck. If there's slanted neck, we can insert microimplant more. It means we can have less irritation to soft tissue. This is patent in the USA. Okay, what has changed after using a microimplant? One time in 2004, I did a lecture at the Moyes Symposium. At that time, the chief editor of AZO, Dr. Turpin, wrote about these things. I believe the implant will change the course of orthodontic care and will lead to significant changes over the next 10 years, already more than past 20 years. Nowadays, almost all the doctors are using microimplant, I think. So at first time, when I used this kind of microimplant, I was very, very happy. One of my job is to treat problem cases, which were treated by my student. In Korea, a professor cannot have their private clinic, so I have to work in the university hospital. And 2 years later, they have to join the army, they have to go out. There are so many problem cases. As you know, 2 years is not enough to treat almost all kind of patient. First, I was very happy I can solve so many problem cases. This is the former case. Then I change the bracket position. Then I insert 3 microimplant. The last two, this is length of microimplant, and the first two, this is the tapered one. Neck portion 1.3 millimeters, end portion is 1.2 millimeters. I always like to use very thin one, if possible. I will talk about the size of microimplant later. And during angmus retraction, also I can intrude anterior teeth. In the lower, there's no more remained extraction space, so I try to use conventional one. And yet it was finished like this without patient cooperation. So nowadays, we can treat the patient without patient cooperation. It means nowadays, my case and my student case almost same. There's no difference in between beginner and expert. So I have a more free time because I do not spend much time to treat problem cases. Anyhow, after using microimplant, I think diagnosis is almost same, but treatment plan changed a lot. Anyhow, the most difficult thing to diagnose malocclusion is borderline case. It means some cases can be treated without extraction, some cases can be treated with extraction. Some doctors non-extraction, some doctors extraction. That situation is very, very difficult. Also, we have to think about patient cooperation. But nowadays, treatment plan, we can make a treatment plan very, very precisely. Today, I cannot show these cases. We can treat so many difficult cases using very small, tiny microimplant. Also, appliance, there's no anchorage loss. It means we have to retract. We can retract anterior teeth more. So also you have to think about torque values, especially anterior teeth. Also, in many cases, I'm using microimplant as a retention appliance with some kind of clear liners. Okay, here I'm going to talk about terms in skeletal anchorage. One time I did lecture in the USA. One doctor sent me an email. Dr. Kyung, the term microimplant is incorrect. Mini implant, mini screw is correct term. So I didn't know the difference between the mini and the micro at the time. But when I look at textbooks, there are so many terms of micro. Tongue is very, very big compared to implant. Finally, I know the difference between the mini and the micro when I did the lecture in the Greek Orthodontic Society. The president wrote me that the mini came from English, micro came from Greek. So same meaning, just small. However, when you make something, we put the name. It became smaller. We usually called it. We put mini. Already we have implant. Also, we have a temporary mini implant for orthodontic purpose. If we make more small, then usually we say micro. So that's why we named it microimplant to differentiate it. Conventional temporary orthodontic implant and orthodontic implant. Many Americans use this term, TAD. But I don't like this term because all these things are TAD. Facebook, lingual arch, TP bar, JHEDIA, all are temporary anchorage device, not permanent anchorage device. Then why many doctors hesitate to use skeletal anchorage for a long time? Because at that time there is good solution to intrude anterior teeth without using this kind of dangerous tools. You know, this intrusion arch, 1 piece, 2 piece, 3 piece, or you treat arch wide. This is one data why many doctors hesitate to trace microimplant because they worried about root damage. They worried about this kind of root penetration. This was done by oral surgeon. Dr. Graber, he invited me in Chicago. I did a one-day lecture, and he showed me one case. Okay. Root is here, crown is here. Because the oral surgeon absolutely cut root. So he applied the force, only crown moved distally. So also, at first time, I was about root injury. Also, I was worried about ankylosis. However, as you know, according to many researches using dogs, also we did this kind of research using dogs with the microimplant. There's no sign of ankylosis. Fortunately, this very famous research about periodontal healing after replantation. And their conclusion is that if the surface irritation is less than 4 square millimeters, ankylosis disappears. It means we do not use very big implant. Usually tip is 1.2, maximum 2.0. So it means even though we scratch or touch the root, we do not need to worry about ankylosis. Because this is kind of a big injury to the root when we do apicectomy. According to this article, about 5% of the apicectomy patients had ankylosis. Also, I think you read this article. Professor Kilomas, when I visited Turkey, he gave me this important material. So this is artificial injury in a human being. Also they encroach to the dentin portion. His conclusion is that even though he encroached dentin portion, there is a process of regeneration. One of my student in Seoul, he penetrates root like this. Like this. Unfortunately, he didn't cut. So patient have to receive endodontic treatment. Here I can see some kind of healing process. I'm not sure. It means ankylosis does not look like a big problem, but just small touch by microimplant, no big problem. But what is the advantage when you touch the root? One of my friends unfortunately passed away. Professor Kuroda did this kind of research. I think many of you read this article. And he classified into three categories after placing microimplant: in the middle, near, and touch to the root. Then compared the success rate. So microimplant is in the middle, highest success rate. Even touch to the root, success rate was 62%. But still, there's a controversy. Root touch makes more failure or not. And many doctors agree if microimplant touch root, we can have more failures. Then, how much do we touch root during microimplant placement? Long time ago, I did a course in Japan. Then I asked them to cover this portion with this kind of tape. Then I asked them to drill 1/3 of orthodontist touch the root. So then I asked to my student to do this kind of research. We made this kind of artificial model. I chose the most common 6 sites to place microimplant, and I asked them to insert between root 6 common sites, this interradical space. We mounted the phantom and this contact ratio of a total group. However, as you can see here, there's difference between the right side and left side. Almost all the forensic side doctors are right-handed person. Also, here you can see contact rate, contact point on right side, left side differ. I think there's some kind of optical illusion when you place microimplant directly into the mouth. So this research was published in AO 2010, long time ago. So I asked one of my students again to make this kind of drill guide. Then we can reduce the total contact ratio from 30% to 70%. Anyhow, I think root touch doesn't look like a big problem. However, it will increase failure rate. Next one is infection. Many doctors also, I was very worried about this kind of infection when I placed microimplant. For the first 3 years, I always prescribed antibiotics. After that, during the last 20 years, I have never prescribed antibiotics. I think this microimplant is more safe than this kind of piercing done by lay people. Still, many doctors, orthodontists hesitate to place a microimplant. But why? Why doctors cannot place these kind of small things? All the dentists have to know how to extract teeth. Placing microimplant is very small surgery, I think, not surgery, operation compared to extraction, I think. You can see big implant in between brain. Several years ago in Korea. And Koreans drink a lot, maybe second in the world, number 1 Russia. And after drunken, he hit his head. Sometimes he felt headache. He visited a medical doctor. Medical doctor told him, do not drink too much. And 5 years later, there is chance to take X-ray. Then they found big implant in between brains. It's not sterilized one. Do you know why? Why there's no inflammation? Russian doctor knows the reason. When I did research in Russia, he told me he drink alcohol every day. The alcohol sterilized. And then, anyhow, as I said before, I never prescribed antibiotics. during the last 20 years after placing microimplant. Then, which size is better? Some doctors use very big one, some doctors use very thin one. This one data from Japan, we compared mini plate and a really big size of microimplant and a small one and the mini plate. According to him, the smallest one, 1.3 diameter, smallest one has the highest success rate. And statistically, there's no different success rate. Another one, when he used very thin one, next day there's no pain. Also, I placed a microimplant by myself, almost no pain. However, when you use a bigger size, patient feel pain. Sometimes they feel 1 week or 2 weeks. That's also one reason I prefer to use a very thin one. If you receive, how to say, injection, nowadays the needle is very, very thin. Older one is very thick. Why? Because thin one, less pain. Also less injury. This case treated one of my students, 43 years of the same year, anyhow. He placed 1.2 millimeter surgical screws. Length was 4 millimeters. Then he tried to retract whole mandibular dentition back. I think this is the biggest. We need the biggest power to move whole mandibular dentition back in adult patient. As you can see here, only 4 millimeter length, 1.2 millimeter diameter is enough to apply any kind of orthodontic force. That's why still I prefer to use a small one if possible. Always, when I teach my student, before starting treatment, you have to think at least 3 times. Think and think and think, then choose the most appropriate appliance and the biomechanics, everything. So and also you have to think about effectiveness and efficiency too. Then you may choose the most efficient one. But sometimes we need effective one too. So anyhow, our conclusion that big size microimplants are not needed for orthodontic purpose. Why? And a microimplant made of usually titanium. Some companies stainless steel, but I heard that also they changed to titanium. Titanium is very, very abundant metal on the earth. It means not so expensive. However, these days we use titanium alloy or grade 3 or grade 4. What's the difference between grade 1 to 3, 4? These are called pure titanium. There are 4 kinds of pure titanium. Grade 1, 99.5, 4, 99. Yield strength, tensile strength, big difference. Ganami used this one, but I started to use grade 2. Then I changed grade 3 and grade 4. Fortunately, there's no difference in success rate. If these numbers goes up, cost more. Grade 1 is very cheap, but less osseo integration power. At that time, always we think about osseo integration when you place implant. Nowadays, almost all the microimplant made of this alloy, 6% aluminum and 4% vanadium. This is same composition of titanium golf drive, same composition. How to make implant or microimplant? So still many doctors, if microimplant is bigger, it costs more. It's absolute opposite. The microimplant size is smaller, the longer it costs more. Prosthetic implant, it takes 3 minutes. Also microimplant, it takes 5 to 8 minutes. Also more inferior goods when you make it small. This is the most commonly used one in my practice. Almost all medical facilities are used this size. I use this side. Even I can insert without drilling. I have to change the material from pure titanium to titanium alloy. Okay, many doctors ask me why do you use stainless steel. Stainless steel, they say strong, but we cannot use this kind of very, very strong SS material like instrument. Only American FDA allowed to use SS 316L. This is a breakage point. This titanium alloy, red one is stainless steel. And your stainless steel, it takes more time to be broken. In the market, you cannot see the inside of stainless steel microimplant, usually big. If you use the same diameter of titanium material alloy, it's almost impossible to break with your hand. So to prevent fracture, the most important thing is to know the breakage point of your fingers. If you feel heavy resistance, if you rotate your pencil, if heavy resistance, it's 10 Newton centimeters. Okay, 10 Newton centimeters. So it means you cannot rotate with your two fingers. It's better to remove, then drill, then reinsert. That is best way to prevent fracture, to increase success rate. And we did this kind of research, and there's no difference. Sometimes more failures when I use stainless steel. Also, stainless steel contains nickel. Many patients have a nickel allergy. Coating. Also, I tried, anyhow, the conclusion. There's no difference. Sometimes more failures when it's some kind of coatings. So here you can see one case. He pressed two grade 2 pure titanium screws, 1.6 millimeters at that time. What happened? He could cut because he couldn't remove. Orthodontic microimplant should be removed easily. That is a big difference between prosthetic implant and orthodontic implant. That's why we changed from cylinder type to taped one. Taped one is more easy to remove. Install microimplant. Now everybody knows I want to skip. And now there are two ways: self-drilling, pre-drilling. Especially for the starters, I recommend to do the pre-drilling. In some report, pre-drilling has more higher success rate than self-drilling. But also, including many orthodontists insert without drilling. However, when you drill, without drilling, you should be very careful about this kind of cortical bone damage when you insert a little bit oblique direction. Initial tightness, according to one doctor in Japan, less than 10 Newton is higher success rate. Higher success rate. It means heavy initial tightness do not guarantee higher success rate. Higher success rate. Force application timing. Many doctors knows we applied immediately, no problem. And when I try to remove the microimplant 1.3, 1.2 diameter in bovine lip, I have to apply 23 kilogram force. But when I apply force laterally transverse like this, when I applied 20 kilogram force, it was broken. Where is also the force? Here. It means we do not need big size of implant for orthodontic purpose. As you can see, these things are, we do not need to wait osseointegration after pressing this kind of screws into the bone. Success or failure, you can search in the article. Finally, I'm going to talk about last thing, alveolar. And why orthodontic treatment is possible? Because we can have this kind of selective disruption and opposition. It means if you place microimplant like this, if it retracts, this is what will happen. You can see more exposure. This is normal situation, like this. same in the mandible. You can have multiple. However, sometimes you can see this kind of phenomena. After using microimplant, there's no bone remodeling. It means we have to tell to the patient before starting detection of anterior teeth in adult patient, especially when we have to detect bodily, we have to tell to this kind of things. Okay, now we can remove this phrase in the textbook. Thank you for your patience hearing my broken English. Thank you.